Good morning. My name is Dr. Farah Nashi. I'm an allergist working in Luxembourg, and I'm also an AIKI junior member representative of primary care and allied health section. Today, we have the pleasure to host Professor Laia Alsina, who is working as a pediatric clinical immunologist in University Hospital of San Juan de Deu in Barcelona, Spain. She's the senior author of an article recently published in Pediatric Allergy and Immunology Journal that we will present today. So, good morning, Professor Alsina, and thank you for being here with us today.
Good morning, and thank you for inviting me and giving the opportunity to discuss about my paper. Thank you.
Thank you to you. The article we will discuss today is called Sirolimus as an alternative treatment in patients with granulomatous lymphocytic lung disease and humoral immunodeficiencies with impaired regulatory T cell. So, Professor Alsina, in your paper, you present a case series of patients affected with this disease called granulomatous lymphocytic lung disease and humoral immunodeficiency. Could you please give us more details on this condition in terms of epidemiology, clinical features, and the different treatments currently used?
Okay, so first, the name is complicated about this lung condition. In fact, granulomatous lymphocytic lung disease is a non-infectious complication of some primary immune deficiencies, most of them humoral immunodeficiencies with immune dysregulation. It's also called GLILD to make things easier for us to discuss later. So patients with primary immune deficiencies have lung involvement in about 40% of the cases along on their lifelong. And of these, usually what is more known is that they develop bronchiectasis, which is a typical feature of the patients. But what is known now is that between 8 to 20% of the patients with humoral immunodeficiencies will develop this non-infectious or inflammatory condition that is called GLILD. So this condition develops manifests usually with asthenia, of course, cough, dyspnea if it's led to progression, and in the long term can lead to a respiratory disease that is really worsens the prognosis of the patients.
Okay, thank you. So, in your paper, you wrote that there is a possible role of Tregs in the development of GLILD. Can you please elaborate this concept and provide a few more insight in the potential immunological mechanisms?
So this condition is, for now, not well known what triggers it. We don't know if it's a chronic infection of the patients or the the underlying primary immune deficiencies in which there is an immune dysregulation and all the T cells and B cells, they get crazy and they lymphoproliferate and they invade the lung. So we still don't know what triggers the condition, and since we don't know what it triggers it, we don't know how to treat it. So this is a big problem in other conditions related to immune dysregulation because we don't know exactly the target of the treatment that we want to use. So for now, what has been used are steroids as first line, which are usually usually improve the condition, and also combinations with rituximab and azathioprine. The problem is that these medications are also associated with secondary effects, and some patients cannot use these medications because of an underlying condition. So we wanted to use or to propose another approach for these patients, and this is why we tested T regulatory cells, which are T cells of the immune system that inhibit T cell proliferation and B cell proliferation. So by increasing them, maybe we will restore the equilibrium and reduce this lymphoproliferation in the lung. So this is the hypothesis we tested in this case series, and it seemed to give good results, but of course it needs to be confirmed.
Thank you. So indeed, you reported a positive response to the treatment with sirolimus in these two patients. Can you please first remind us what is sirolimus and the mechanism of action, and then tell us why you should prompt the use of this molecule over the all other treatments available right now?
So sirolimus is also known as rapamycin. It's an inhibitor of the pathway called mTOR. This pathway is used by many cells for proliferation, and specifically T cells use this pathway downstream IL-2 receptor to mostly proliferate. So this drug on one side inhibits the lymphoproliferation, but on the other side increases the Treg numbers and function because they have an advantage over the other cells. So there is a combination of inhibiting and promoting the regulation of the system, and it's a drug that can be taken orally, and that has some side effects, of course, aphthise in the mouth. Then they can cause, on the long term, dyslipemia and sometimes proteinuria and hypertension. But if it's given for a short period, maybe at most like 2 years, maybe it can help regulate the immune system in these patients. Some of them who cannot receive steroids because of pre-diabetic condition, for example.
Very interesting, thank you. So to summarize, would you please provide one or two take-home messages related to this study you recently published in Pediatric Allergy and Immunology Journal?
So my first take-home message will be to identify patients with humoral immunodeficiencies, I mean with B-cell defects, that have this lung disease, because early diagnosed and early treated, it doesn't condition the prognosis of the patient. And this is the first thing, and it's usually diagnosed through a scanner. And also that we need more integrative work with other specialists and other centers to confirm these results and to identify the mechanisms underlying this disease to better target the immune system with the drug that gives less secondary effects, which is what we all need for our patients.
Perfect. So thank you very much, Professor Alsina, and thank you for being here with us today. Have a nice day. Bye.